get started here. I am really happy to introduce today's Grand Round speaker, Claudius Marr. Claudius is, shockingly to everybody in the room, originally from Germany, from Munich, where he studied, at least got through undergraduate, where he graduated magna cum laude, and then came to the US and went to medical school in Chicago, then did his internal medicine residency at Northwestern, and then got cardiology training of a variety of sorts. Who knew? He's actually did an imaging fellowship as well. Stay away from my echoes. And he did that all in the Chicago area at a couple of different spots, and then was at the Medical College of Wisconsin doing essentially what he does here, which is developing MCS programs and heart failure. And then he came to the University of Washington 4 years ago, tasked with helping to further advance our VAD program, mechanical circulatory support, and heart failure, which had been robust and has been even more robust since. And in particular, because of involvement in clinical trials. So he's been a driver in having multiple clinical trials here for VADs, 4 of them ongoing right now. And has been incredibly productive in that regard. He's got a ton of publications in this new thing we have of clinical faculty who have a ton of publications and are really active in research. Claudius is decidedly amongst them. And in honor of him, I wore slightly pointy-toed shoes. Just to make sure, and on a personal side, Claudius is one of the most hilarious people I've met, and he's got a phrase that I've stolen from him repeatedly whenever we're talking about the fantastic things we're going to ask the surgeons to do, said with the courage of the non-combatant. Of course the surgeons can take this guy and put a VAD in. So I will, with the courage of the non-combatant, sit back and let Claudius give us some hot topics updates on heart failure and MCS. Thanks, Claudius.
Thank you, Karen, for that very generous introduction, and thanks for finding time to join us for this. Here are my disclosures, and I'm an equal opportunity offender when it comes to my industry interactions. I don't play favorites. I have one additional disclosure, and that pertains to acute heart failure and cardiogenic shock. I'm actually embargoed from talking about the Shock 1000 registry data that's going to be presented at TCT and AHA. So what I thought we would focus on a little bit is just the lay of the land in advanced heart failure and some of the things that are affecting us as an institution, as a program, and as a field. And I'm going to spend the bulk of my time talking about some of the things that we've been done thanks to your support and the engagement of our team here, and focus on some things that recently are, I think, very exciting. So here's the requisite heart failure is common, bad, and expensive slide. You're all familiar with it. What's really depressing about it is that every year I give this talk, I slightly have to up the prevalence data because it continues to get worse. And this is against the backdrop of a static organ donor pool and an increasing number of patients with advanced heart failure. So this is going to continue to get worse. And if that's not depressing enough on a Friday morning, these are the Kaplan-Meier curves for patients with advanced heart failure who become neurohormonal therapy intolerant and inotrope dependent. And what you notice is that there's a very, very steep attrition early in that trajectory, and that by 1 year, 90% of patients have died. So for our fellows, if you take away one thing from this presentation, When you call me at 3 o'clock in the morning, like you guys have been every other night, and you say, Mrs. So-and-so, it's her 5th admission, she's on 7 of dobutamine, her creatinine is going up, but she's quote-unquote stable on an inotrope, this is the image that comes to my mind. There isn't another cardiovascular disease process in which you would say 90% 1-year mortality with 2/3 of these deaths happening very early can be characterized as stable. So I think it's a misnomer, and I think we have to stop referring to it as such. So taking a step back and putting on my medical director hat, what I really want from our advanced heart failure program is patients that are desirable, straightforward, surgically and medically gratifying. And they're essentially less than 60, shouldn't have had any prior surgeries, have minimal comorbidities, no end organ dysfunction, of course no adherence limitations, and should have excellent social support. So for those of you that would come to our Thursday morning meetings, this is essentially what we're looking for. We're searching for very elusive unicorns in a very, very large field of cows. Because the patients we actually get referred to us look like this. Typically, they're in their 70s. Most of them will have had 2, if not 3, prior cardiac surgeries. They have lots of non-cardiac comorbidities, typically some degree of end organ dysfunction. Many of them, over half in our program, have some degree of cardiac cachexia. And of course, as Dr. O'Brien can attest to, since he and I are currently on service, it's very, very difficult to assess adherence when somebody's in the CCU with a percutaneous ventricular assist device. What does that look like at best? It looks something like this. So for those of you who don't remember, this is Dick Cheney, the former vice president. He arguably had most of the cardiovascular interventions that we have, including a ventricular assist device, as well as a heart transplant. And while arguably advanced heart failure therapy improves quality of life, in his case, he was able to go out and hunt and engage in his activities of daily living. We're still far from where we should be, and our outcomes remain such that there's room for improvement. It's also clear that advanced heart failure therapy presentations have shifted, because if you think about the amount of interventions that you have to fail before you end up in an advanced heart failure program, thanks to statins, goal-directed medical therapy, revascularization, medical therapy, ablations, the mitral clip types of things. Really what we're seeing is about a decade shift in advanced heart failure presentations from what historically was the case. And this is against the backdrop of something else that's affecting us, and that's the 2018 brand new, soon to be implemented UNOS heart allocation system. And for most of us in the transplant business, this is the connotation. So if you recall the current heart allocation scheme in the US, we have 3 relatively neatly, albeit imperfectly defined statuses. And in a matter of weeks, those are going to be replaced with 6 new statuses, which creates not just an administrative challenge, but a formidable logistic challenge and the associated issues. So in order to end up in the high urgency domain, you need to be super sick, and that's readily apparent up front. So the status 1 patients are non-dischargeable short-term MCS patients and either biventricular support or ECMO. It's interesting that a intra-aortic balloon pump or univentricular left-sided support only buys you status 2. And then what formerly was the elective 1A time for LVADs now is status 3. And probably more disconcerting, multiple inotropes and the PA catheter is the third status. So if you think about this conceptually, this has major, major implications. There's also some inherent safeguards built into the system, and that's to say that if you're fortunate enough to survive ECMO for more than a week, you end up dropping to status 3. So really the system is designed to preferentially transplant sicker patients. And what the implications of this are, we're not really sure. We anticipate that 1-year survival will actually decrease. And it's also, I think, fair to say that the resource utilization programmatically will increase. That's the bad news. The good news is every program in the country is in the same boat. So we're going to muddle through this together and see where this journey takes us. Our own Dr. Dardas did a really, really nice review of a recent publication on this issue. And if you haven't read it, I would encourage you to read his wonderful editorial that's associated with this. And by the same token, it's clear that our field of how we manage advanced heart failure has not remained static. This is HeartMate 2 data, and the HeartMate 2 has essentially become a legacy device. We try not to implant any new ones anymore. But you can see that the outcomes, even with this device, have improved from generation to generation. So every subsequent era of HeartMate 2 patients has done better than the previous one. And this was still an axial device, requires a preperitoneal pump pocket. It's surgically a little wonky. And this has led us to the incremental change of the centrifugal devices. So you have the Medtronic HVAD and the Abbott HeartMate 3. They look remarkably similar. There are some nuances between the two. They sit directly on top of the heart and pump blood from the failing left ventricle into the ascending aorta. What can be expected from these devices? As you can see by the 1-year expected survival, if we're implanting cardiogenic shock, crash and burn types of patients, survival is much worse than if we have these semi-elective types of patients. And I think the expectation is that one could get to 90% 1-year survival with the current devices with proper patient selection and proper management. How do you get to that point? Well, this kind of flies in the face of what we just talked about with the new UNOS allocation system, because it really presupposes patients that are devoid of any end organ dysfunction that they have to be resuscitated from, and really catching people at the tail end of tolerating neurohormonal therapy, but before they have things like cardiorenal syndrome and need to be resuscitated from that. What does this look like in the real world? This is the most recent data set we have. This is the HVAD thoracotomy trial. So these are highly selected patients and underwent non-sternotomy VAD implantations. And in this study, which hasn't been published yet, but we submitted and hope to have published soon, we were able to accomplish 87% 2-year survival. So recall 90% 1-year mortality on an inotrope, and this is a pretty remarkable outcome. So if that's the case, then we can say, okay, I'm done. It's the end of the talk. Enjoy your day. Turns out, unfortunately, it's not that simple. This is Intermax data. and it captures all VAD complications. And they can be as trivial as the first readmission or some broken clip or a battery malfunction, or they can be as dramatic as serious adverse events. And you can see that in this case, 90% of LVAD patients end up getting readmitted in the first year of their implant, most of them a lot. So how do we have the conversation with our patients in the CCU who are sitting with impellas, and we're approaching them about whether or not they want a durable ventricular assist device? It turns out it's a pretty coercive conversation, right? So when somebody's faced with multi-system organ failure, there's really very limited options, and sadly, that's the position most of our patients are in. It's also clear that adverse events perioperatively greatly impact outcomes, and they do so in a cumulative fashion. So patients who have 0 or 1 adverse event after their LVAD implantation actually do as well or better than patients who go straight to transplantation. But the more adverse events a patient amasses, the worse they do, and this again happens in a cumulative kind of fashion. So Joe Rogers wrote this tongue-in-cheek editorial in which he said essentially what we're really going to be doing for the rest of our careers is managing LVAD complications. And this is what we're going to talk about next. So for as mechanically reliable as the devices have gotten, they have some dramatic and fixed limitations. The first is that they have continuous flow at a set speed. And there's no afferent or efferent connection. They're completely non-adaptive, and there are no sensors in the current devices. So that means whether a VAD patient is asleep or exercising, whether they're at the nadir of their blood pressure or GI bleeding, whether they're in clinic hypertensive, the LVAD will spin at the same speed. And the other physical reality is that the devices are very preload and afterload sensitive. And anytime you increase LVAD speed, you deliver more blood to the right side, and the right side has to be able to handle that. So this brings me to the next issue, and that's we've seen an increase in right ventricular failure when we've moved from the axial devices, the HeartMate 2, to the centrifugal devices. And there's a lot of conjecture about this, but I would submit to you it's actually relatively straightforward. These are the dreaded HQ curves for the centrifugal devices, in this case the HVAD. And you can see that they're relatively flat. So the pressure differential between the left ventricle and the aortic root determines blood flow. And to make this straightforward, if afterload decreases, flow goes up, and if afterload increases, flow goes down. And that relationship is preserved at any VAD speed, but it's important to keep in mind that with a variation of about 20 to 30 millimeters of mercury in blood pressure, the flow will increase by as much as 50%, and technically, if blood pressure goes from 50 to 100 or vice versa, you're going to get somewhere between 0 and 10 liters of flow per minute in the same patient. So the most important determinant of actual VAD flow is afterload, mean arterial pressure, and not VAD speed. And as it turns out, and we presented at ASIO this year, the device-derived and displayed flow is notoriously inaccurate, and the parameters are very counterintuitive because they're predicated on power consumption. The only thing that the pump measures is how much electricity it consumes, and the only thing that you can set is the speed. So sometimes on rounds, the liters per minute display turns into a somewhat of a road rage speedometer, because if you expect to see 5 liters of flow per minute on the device, you may be disappointed when you compare this to a right heart cath. This has a lot of implications, and those include that any kind of right-sided hyperemia will result in elevated filling pressures, elevated wedge pressures, which puts a lot of strain on the right side of the heart, and probably is the pathophysiology between RV failure, GI bleeding, diuretic refractory types of states. So if you lower mean arterial pressure without decreasing VAD speed, this will result in RV pressure volume overload. And this is probably the mechanism of these associated issues. So the devices have become much more reliable, but I think as anybody who sees these types of patients can attest to, the complication rates still remain too high. And the most devastating complications really are stroke and device thrombosis. So this is, again, Intermax data, and you can see that early on, all bets are off during the implantation. There's all kinds of things that can happen. But if the patient makes it for a couple weeks post-implantation, really neurologic events are the primary cause of death and the major source of morbidity and mortality. And this is different from the pulsatile devices that we used to deal with, because in the pulsatile era, the mechanical reliability of the devices was such that it was really the device itself typically that would fail. Whereas here, the devices have gotten so good that they will continue to work as long as they don't lose power or ingest something. And the neurologic morbidity and mortality has continued to increase. And if you take a step back and think about this for a minute, it's not entirely surprising why that would be the case. We have a metal object inserted in systemic circulation, the apex of the left ventricle, and we have areas of stasis and high shear from continuous flow and an association of an element of endothelial injury. So all three boxes of Virchow's triad are essentially checked. And when we decided which clinical trials to participate in, one of the other issues we realized was that it's not enough to say, let's try and use the latest generation devices, but we're obligated to our patients to identify what the best strategies of managing these devices are. And the observation that our total artificial heart patients had above average event rates for embolic strokes resulted in the genesis of our own UWMC anticoagulation dataset. So this is the dreaded anti-10A project. It's consumed more time of mine than any of the multi-center clinical trials. Thanks to our colleagues in the CCE, we now have the largest prospective paired anti-10A PTT cohort in the world. We have 16,000 samples in 527 patients. And the majorly surprising finding was that 67% of patients had elevated PTTs, but no demonstrable heparin effect compared to anti-10A. We went through great length to try to capture all of the associated AEs via our PSN system. And we're still in the middle of analyzing this data, and no one wants to get this out more than I, just out of self-preservation and hoping to be done with this. But here's our preliminary data. So blue is no bleeding, red is bleeding, and it turns out that PTT fails to predict bleeding. And this is all comers with a very, very honest, non-adjudicated bleeding definition. Anti-10A, on the other hand, strongly correlates to bleeding and in a dose-dependent fashion. So when you get to an anti-10A that's above our target range, when you get to about 0.7, 0.8, there's a pretty compelling dose-dependent relationship between anti-10A levels and bleeding. This looks like a Jackson Pollock painting, and this is again PTT associated with bleeding. It turns out that MCS patients bleed at any PTT, and they also clot at any PTT. So there's lots more to come about this, but this is a very, very large data set, and anybody who wants to work with us on this is welcome to. But our preliminary data suggests that anti-10A monitoring is safe and PTT fails to reduce clotting nor predict bleeding. And the discordant panel that we put together in collaboration with hematology has been very, very labor intensive, but unfortunately hasn't helped us much. So there's a lot of additional work that will be done in this regard and more to come. So one of the other things that became apparent in the discussions about our multi-center clinical trials is that it's not enough to say, can we figure out the anticoagulation piece? We also need to figure out the blood pressure piece. Because somebody with a continuous flow device and no readily measurable pulse is difficult to manage, and no one really knew exactly how blood pressure should be measured in patients with continuous flow. So there are lots of opinions in this field, none of them supported by science, and people felt very, very strongly about this issue. So there are some people who thought that you can slap an automated cuff on a patient with an LVAD, and if you get a number, any number, that's probably okay. There are other people who said, well, maybe Doppler opening pressure is the way to go. And then there are the purists who say, really what you need is an A-line to look at mean arterial pressure, pulse pressure, and the relationship of these. So the original Medtronic HVAD trial had a signal for more frequent neurologic events. And when FDA was approached to get approval for the HVAD, they saw that signal for excess neurologic events and mandated another clinical trial. And that additional clinical trial was the Endurance 2 trial. And Endurance 2 was a randomized prospective clinical trial, the HVAD versus the HeartMate 2. That was the only available device at the time. And the endpoint was blood pressure control and freedom from stroke or device thrombosis. And as somebody who was involved with this study, and as one of the top enrolling sites in the country, this was not an easy clinical trial to do because both clinicians and the industry colleagues had very, very strong opinions as to how this should go down. This is what it showed. It turns out that the HVAD device was superior to the HeartMate 2 in this case, and it met the criteria for superiority. But then when you look a little bit deeper at blood pressure control, it wasn't really prescribed how blood pressure was supposed to be measured and how blood pressure was supposed to be controlled. So we made the deliberate decision that if we're gonna go through this trouble of doing this trial, we're gonna have to measure blood pressure reliably, consistently, because otherwise our own data is gonna be very, very difficult to interpret, because just slapping a cuff on somebody and recording that number was obviously fraught with problems. So if you look at the number of patients who actually had their mean arterial pressure controlled, it's more than half but it's still not that great. Did it matter? Thankfully, it wasn't a total waste of time. Yes, it does matter. What we saw was a 50% reduction in the risk of hemorrhagic neurologic events. But again, the challenge with a trial like this is if you work in a center in which there's sort of a nihilistic approach to measuring blood pressure, we don't know what it means, we don't know how we should measure it, you end up with data that is far from perfect. It's encouraging that blood pressure control alone improved the rate of hemorrhagic events, but it's not sufficient to really answer the question deliberately. So if you're a glutton for punishment and you're unhappy with your multi-center clinical trial, then what you do is you go back to your own institution and the original question. And the original question was, what is the ideal way of measuring blood pressure in VAD patients? So I want to express my gratitude to the entire MCS team and the 5 Northeast and CTICU nurses who have indulged us with this, because we prospectively decided we're going to take blood pressure with Doppler in all of our patients. And this was a very, very large QI project and one that I'm extremely happy with. So Dr. Lee graciously agreed to take the lead on this, and Jennifer Beckman and Jason Belkengren are responsible for the QI in this part. And with that, we have 1,933 pairs of Doppler opening pressures versus A-line pressure readings in 154 of our own VAD patients. Which, to put this in perspective, Endurance 2 multi-center clinical trial, we have more blood pressure data at UWMC than the rest of the entire clinical trial. What does this look like? We were really surprised by this because a lot of us had the preconceived idea that if the pulse pressure widens, if the ventricle is small, if there's all kinds of variables and all kinds of conjecture, that really Doppler opening pressure may not accurately represent mean arterial pressure. But as it turns out, it does for the vast majority of patients. So most patients, 87%, are within 10 millimeters of mercury Doppler opening pressure to invasive mean arterial pressure, and the vast majority of patients are actually within about 3 millimeters of mercury, which arguably is excellent for clinical decision making. So we've established and hope to soon publish this, that Doppler pressure is the way to go in patients with continuous flow. And if we're going to make a dent in adverse events and neurologic outcomes, this is really what we need to do. And here's why we're doing this. This is a patient of mine from a previous institution. HeartMate 2 showed up in clinic with a INR of 1.9 and a headache. She got admitted for a heparin drip. Here's her first head CT. This is her second head CT after 6 hours of heparin. So what happened was an embolic event through the device, and ultimately she had a remarkable recovery, underwent percutaneous therapy of that embolic event. But this, I think, is emblematic of the challenges we're dealing with when it comes to improving neurologic outcomes for LVAD patients. Industry is very interested in this. This is an analysis that was just published in Circulation, and it's a little bit more granular look at the neurologic events in the HeartMate 3 cohort. What you see off the bat is that not having a neurologic event versus any neurologic event has a dramatic difference in outcomes. And the messaging of this paper, I think, is somewhat overstated. Because if you take a step back and you look at what patients actually care about, fatal and disabling strokes, unfortunately, there was no difference between the HeartMate 2 and the HeartMate 3. So this is a little different from the narrative that is out there, but I think from a scientific standpoint is important to keep in mind that while it is encouraging that there is a signal towards improved outcomes with the third generation device versus the second generation device, it's not really enough to say, okay, well, one is better than the other, because when it comes to adjudicated severe neurologic events, there's actually no difference. It's hard to compare neurologic event rates across different clinical trials. We tried to do that anyway. So Dr. Lee and I did this back of the napkin mini meta-analysis where we took all of the recent neurologic event publications and went through the trouble of calculating events per patient year and tried to harmonize what the actual outcomes are. And as it turns out, the total neurologic events between devices are remarkably similar. And when you ask yourself which strokes should count, talking to patients, really any stroke counts. Most patients are more afraid of a disabling stroke than they are of dying. And in that case, it's clear that no device is better than the other. So HeartMate 2 versus HeartMate 3, just looking at disabling and fatal stroke, there are actually more disabling and fatal strokes with the HeartMate 3 than there were with the HeartMate 2. And if you look at, again, disabling strokes, we have not made a lot of progress between different devices. So there has to be something else that's contributing, because if you adjust LVAD patients in a propensity-matched fashion to other disease entities we deal with, atrial fibrillation, mechanical valves, things like that, there is something more to it than that, because there's something about how the patient and the device interact that makes this more thrombogenic than our garden variety types of patients. So this is something that we're spending a lot of time on, and we're trying to learn as much about as we can. And there's a lot of interactions that happen between the device and the patient that play into this. And from a historic standpoint, the device companies have focused most of their research and development on the pumps themselves. Everything else was largely an afterthought. So it was really about impeller design, improving hemolysis within the device, and everything else looks like somebody just grabbed random pieces from Radio Shack and assembled them and turned them into a ventricular assist device. And that includes the other factors that are associated with this. So one of the major issues that contributes to thrombogenicity is the angle of the inflow cannula. So if you think about this conceptually, if you have a large globular left ventricle, you want the inflow cannula to be as neutral and pointed down the barrel of the heart as possible. Because if it isn't, what happens is you have an area, one side of the ventricle, that is really, really high shear. And you have the other side of the ventricle that has very long residence times. You can improve one of the two of these variables, but if you improve one at the expense of the other, you end up with unfavorable outcomes. So, not a super complicated concept, but clinically very, very important. The other issue that plays into it is VAD speed. If the VAD speed is too high or there's too little residual native contractility and the aortic valve never opens, you end up with an area of subvalvular stasis that's essentially very, very thrombogenic and a lot of stress on the aortic root. This is represented here in one of our studies where we just looked at what would happen if the aortic valve opens even partially, intermittently, every 4th to 5th beat. And you can see that wall shear stress in the aortic root is dramatically higher in patients in whom their aortic valve does not open versus the valve opening intermittently. Small LV size is another newly described risk factor for VAD thrombosis. And again, it's a relatively intuitive concept. If you have the same amount of fluid going through a big funnel versus a small funnel, you're going to get higher velocities, higher shear. And then other more nuanced types of things like the outflow graft configurations. So this is what we're doing in our lab, and this is our research that we're doing translationally, and obviously I'm a big geek, and that's why I'm boring you guys with this stuff. So to take it to the level of where it actually makes sense, the take-home message is laminar flow is desirable and physiologic. And I'm using a Food Network analogy here. Turbulent flow is highly, highly thrombogenic. Again, the concept of high shear and long residence time. And this has major implications for the biocompatibility of the devices. So it's imperative to achieve ideal surgical inflow cannulation. Super easy for me to say, and again, speaking with the courage of the non-combatant, because we're asking our cardiac surgeons to take a deflated heart in a patient whose chest is opened, and then aligning the inflow cannula just so to make sure that it's pointed down the barrel of the left ventricle. There are a lot of things that I think we can improve, and this is one of them. So these are images that I stole from Dr. Mackinson. It's an intraoperative TE, and he uses his wizardry knobology to essentially give you a really perfectly aligned view of the mitral valve and the inflow cannula. So this is what it should look like in an ideal world. And on color Doppler here, you can see that there's nice laminar flow going into the left ventricle. So this is the desirable configuration. And I'm bugging Dr. Kirkpatrick and Dr. Mackinson all the time, because this is an area that's rife for academic inquiry, and we have a large enough data set where looking at this would be very, very helpful. The other things we're up to, we have a wonderful collaboration with our School of Engineering here, and that's actually where our lab is located. And we've been able to patch together projects where we look at our computational investigations, integrate them with our clinical work, and we're also doing in vitro studies. So we have the ability to take any CT scan, turn it into this eerie looking silicone printed left ventricle, stick any kind of device into it and make it beat, which is really cool. So we're excited that this is going to help hopefully improve outcomes at some point. Some of the things that we're doing already have had a dramatic impact on patient care. So I hope to leave you with some good news. And I think the good news is, though we continue to have issues with complications And neurologic events affect all of our current devices. Our ability to improve our anticoagulation and blood pressure management strategies have had a significant impact on outcomes. And that even with our current commercially available devices, we can incrementally eke out more biocompatibility. And as all of you know, the one thing that we cannot get around is the concept of patient selection and proceeding with advanced heart failure therapy in a timely implantation. At the end of the day, an LVAD only does two things. It lowers filling pressures, it increases blood flow. It does not turn people into better persons. It doesn't make it more likely for them to be gainfully employed. It doesn't address substance abuse problems, personality disorders, or the like. They lower filling pressures and they increase blood flow. So patient selection and the timing of therapy is imperative for good outcomes. So I want to express my gratitude to our entire UW Advanced Heart Failure and MCS team. I owe a big thank you to our colleagues in nursing, pharmacy, neurology, hematology, laboratory medicine, and last but not least, the CCE. And I will take any questions or comments you may have. Dr. Levy.
Excellent presentation. I'm curious if there's any association between your max class and stroke rate, because the problem is even if we have a 7% mortality in your max 4 and 5, if we have a 25% stroke rate of 0.24, which your max showed per year, that's a hard trade-off for patients if you talk about 1 in 4 having a stroke versus 7% dying. And that's one of the big Achilles heels about putting it into lower risk patients.
Yeah, and I think you astutely articulated two critical points. Our ability to predict who's going to have a neurologic event remains very limited. And the patient characteristics are challenging. I think there are some things that we are figuring out that we know, and those are encouraging. But by the same token, given the current neurologic event rate, I don't think we are there to say we should be implanting Intermax 5 or 6 patients. It's really when you get to Intermax 3 where neurohormonal intolerance starts, but before end organ damage. So there's no appreciable difference. And it's so hard to tease this out because, in the 4 clinical trials that we participated in, some of it feels like reading tea leaves, and some of the issues are that we lag in the cardiac community behind the sophistication that our neurology colleagues apply. So we're working with our neurology colleagues on a more detailed analysis, including, and this is something that stemmed from feedback from Dr. Masri, including looking at the timing of resuming anticoagulation after an embolic event, and all of these types of things. But, it's essentially still the data-free zone. Kevin.
Claudius, that's a terrific talk, and congratulate you on this amazing amount of work that you've been able to do. I had a question about, I love the slide about bleeding risk by 10A level, and there's a clear inflection point at 0.5.
Mm-hmm.
So why would our upper limit not be 0.5? Is there some superimposed risk of thrombosis that you could put on that you could overlay on that helps inform that?
Yeah, it's a really great question. What should the ceiling anti-10A be? So when we designed this, we did a literature review, looked at all of the published data sets, and we decided to subtract 2 standard deviations from the typical anti-10A target ranges. So the most common one was anti-10As of 0.9, sometimes 1, were the sort of higher intensity anti-10A levels. And we had no idea. So we collected the data. I suspect the target range will ultimately depend on the thrombogenicity of the device. If somebody is on ECMO with an open chest, they probably just need a measurable heparin level. If somebody has a total artificial heart, 2 Tupperware containers with 4 second-generation Virchow valves, about the most thrombogenic thing we do, we probably ought to be higher than that. But one of the limitations to this is how difficult it's been to analyze this data, and the level of statistical analysis is very challenging. So it could very well be that ultimately 0.5 or 0.6 is what we should be using for the vast majority of patients. And when we noticed the signal, we decreased our short-term MCS anti-10A target to not more than 0.5. So I think the future is going to be, we'll have a super low intensity, medium intensity, and high intensity data set. But again, the compelling part is that how not helpful the PTTs have been, which was really surprising.
Well, I don't miss the point that this is a real advance, and I really applaud you for your efforts with this project.
Thank you for doing that. Somebody has an emotional attachment to the PTT, obviously.
That, on the other hand, is exactly on